Welcome back to the deep dive. Today we're tackling something, well, really complex, straight from your revision notes, conversion disorder.
Yeah, it's a fascinating one.
Our mission is basically to take these notes, unpack them, and pull out the real high-yield stuff, make it clear and memorable for you.
Absolutely. It's a topic that sits right at that mind-body interface, doesn't it? These notes give us a good map, and we want to help you navigate it.
Okay, let's dive in then. The definition first. According to the notes, what is conversion disorder at its core? What's the main thing?
Right. The absolute key thing to remember is you've got neurological symptoms. Things like weakness, maybe paralysis, blindness, tremors, could even be seizure-like events.
Okay.
And this is the crucial part, these symptoms are inconsistent with any known neurological disease or other medical condition. The pattern just doesn't fit.
And there's a link to psychology, right? The notes mention something about unresolved conflicts or distress.
Exactly. That's the conversion idea,
Yeah.
Psychological distress is thought to somehow, well, convert into these physical symptoms.
And critically, it's not deliberate.
No, absolutely not. The person isn't faking it. They're not consciously producing the symptoms for gain or anything like that. They genuinely experience them.
The notes mention labile indifference, that lack of concern.
Yeah, they mention it, but they also rightly caution that you don't always see it. So it's interesting, but not a reliable diagnostic sign on its own. Don't hang your hat on it.
Right. So this is the really intriguing part.
Hmm.
How does this actually happen? The cause, the pathophysiology, it sounds pretty complex in the notes.
It really is. The notes paint a picture of like a disruption, a breakdown in the normal communication lines between the brain and the body.
Okay.
It seems to involve psychological factors, stress, maybe trauma, unconscious conflicts, somehow triggering this physical manifestation. But the precise sort of biological wires involved, we don't fully understand them yet.
So lots still unknown there. What about risk factors? Who's more likely to develop this?
The notes point to a few things. A history of trauma or abuse seems significant. Also, having other psychiatric conditions like anxiety or depression, or even having had genuine neurological issues in the past, and certain personality factors, maybe difficulty handling or expressing emotions.
So given these neurological-like symptoms, how do you make sure it's not something else? What are the key differentials the notes highlight?
Yes, this is absolutely critical for practice. You must rule out actual neurological diseases.
Like stroke or MS?
Exactly. Stroke, MS, epilepsy, depending on the symptoms. Then there are other somatic symptom disorders. And importantly, you need to distinguish it from malingering.
Or someone is faking for gain?
Precisely. Or factitious disorder, where they fake illness, but for like an internal psychological need, not external gain. The inconsistency of the symptoms with anatomy is often the big clue for conversion disorder.
And how often do clinicians actually encounter this? Is it common?
The notes suggest it's considered rare, especially here in the UK. Getting exact numbers is tricky there. It can affect anyone, any age, any gender.
Okay, so bringing it all together, what does it actually look like clinically? The features seem varied.
They really are, because they mimic neurology. You might see motor issues like a limb weakness that doesn't follow nerve patterns, or tremors that change when distracted, odd gaits, or sensory problems, maybe weird patches of numbness, vision loss that doesn't match eye exams, hearing issues, even those non-epileptic seizures we mentioned.
And the key is the inconsistency.
Yes, the inconsistency with organic disease patterns is central, and the symptoms can often shift or come and go.
So with all that, what investigations are needed?
Well, the diagnosis itself is largely clinical. It rests on a really careful history, a physical exam, and a thorough neurological assessment to spot those inconsistencies.
But you still do tests.
No, absolutely. The notes are clear on this. You need appropriate investigations, maybe brain scans, nerve tests, blood work, whatever's needed to confidently rule out an underlying physical cause. You can't miss something treatable.
Right, makes sense. So once the diagnosis is made, how do you manage it? What's the strategy?
It really needs a team approach, a multidisciplinary one. The aim is twofold: manage the physical symptoms and address the underlying psychological stuff.
So therapy.
Yes, psychotherapy is key. The notes mention things like CBT, cognitive behavioral therapy, helping change thought patterns, or maybe psychodynamic therapy, exploring deeper issues. Physical therapy can also be crucial for regaining function.
And keeping an eye on things.
Definitely. Regular follow-up is vital for support and tracking progress.
What's the outlook usually like? Can people get better?
The notes say prognosis varies quite a bit. With the right support put in place early, many people do see their symptoms reduce significantly, sometimes resolve completely.
But not always.
No, for some, symptoms might linger, maybe become chronic, needing ongoing management to help them cope and function.
And what are the risks if it's not managed well? Complications.
Well, the biggest one is just the impact on daily life work, relationships, independence can all suffer because of the symptoms. There's also a higher risk of anxiety or depression alongside it, potentially lots of healthcare visits trying to find answers, and just ongoing distress if it's not properly understood or addressed. What really strikes me here is just how profound that mind-body connection is and how much is still, well, a bit of a mystery. How can psychological distress create such real, debilitating physical symptoms that don't have a clear physical cause? It's quite something.
It really is. This deep dive based on your notes really clarifies conversion disorder, showing the complexity, but also giving us that high-yield framework. Nailing these distinctions is so important.
Absolutely critical. And for anyone revising this or wanting to learn more, good resources are definitely available.
You can find more high-yield content just like this over at pastmsra.com.
Yeah, lots of helpful stuff there.
And don't forget the free resources available too. Check out freemsra.com.
Worth a look. Until next time.